Just like to introduce our next presenter. His presentation is on 988, Entry into the Crisis Continuum. Our speaker today is Angela Roberts. She is the 988 Program Administrator within the Kentucky Department for Behavioral Health. It's been a pleasure meeting you. This is my first time meeting Angela, so we email back and forth, but I've not met you before. So.
Great, nice to meet you. Well, thank you all very much for this opportunity, and I do apologize in advance. I have very little voice, but at least I don't sound like Minnie Mouse like I have for the last 2 days. So, as he said, I am here to talk about 988, and the first thing I'm going to do is I am definitely going to ask for your input, because what we want to know is what people in Kentucky know about 988. So if you take out your phone, if you're from Kentucky, and scan this, and it's a real short survey, I would so greatly appreciate it. The survey closes tomorrow, so we want to get some input from everyone on that. I'll give you a second.
Is this something that you would want us to send to our staff?
You can do that as well. You can share it as long as, to anybody in Kentucky, it closes tomorrow, so that would be awesome. Okay, so let's talk about 988. And as I was listening to this and following my esteemed colleague, Steve, I was going, oh gosh, I don't have a joke, but I figure my voice will suffice in that today. So hopefully everyone is patient with that. We're gonna talk about what 988 is and where it's been and where we're going with that. So just a little bit about me. I've been in this position almost 2 years now. And I never would have imagined working in the Division of Mental Health, because I'm a disaster junkie by trade. I have spent many, many years working disasters, come from a first responder family. I'm a volunteer firefighter myself, and do a lot of things within the community. But I'm particularly passionate about this because listening to Steve and listening to the previous presentation, everything that 988 is doing touches on everything that's already been talked about. And that's where this is important. I'm very passionate about it because there's been mental illness in my family. There has been, my late husband was a first responder. He was impacted by what he saw, but would not seek help. And he would often tell me, I used to work for a peer crisis support team. He would say, leave work at work and stop doing that to me. But I was trying to help him with that. His oldest son passed away from a drug overdose in dealing with comorbidity. I had a friend who was a first responder who committed suicide after dealing with what he went through. So this is of particular importance to me, and I'm very passionate about it. And you may be very well aware, but we have a mental health crisis, not only in Kentucky, but across the country. And this is data that basically shows, I believe this was from NAMI, but in July of 2021, they said, roughly 4.5 million Kentuckians is what the census said. It's now increased by like 16,000 by the latest estimates. But roughly about 70% of our population in Kentucky live in an area where there is not sufficient mental health services. That is significant. If you go pull the maps up and you can check and see where there are healthcare droughts, every Kentucky county is covered, saying that there is a shortage of mental health providers, and that's scary. So that's another reason I am so passionate about what we do with 988. Mental Health America in Kentucky has done some screenings, and this is data from them. They have on their website different screening tools, and this shows in 2022 that the most used tool for screening was for depression, followed by bipolar, and then anxiety. And there was almost, a little over 28,000 Kentuckians took these screening tools, indicating that there's a concern about that. Then we also get into the age bracket. And if you look at this is of those 28,000 plus that took the screenings, the largest age groups were the 18 to 34. So we've got some serious concerns, and people are recognizing that. And we also know that COVID had a significant impact on that. My youngest child is 22 years old. She was a senior when COVID hit. She lost her senior banquet, she lost her prom, she lost her graduation. She had to go virtual. She's not a virtual type learner. She's a very social person. She suffered from mental health because on top of that, in 19, she lost her best friend. We lost my husband who practically raised her. And then we lost his mother all within and I forgot my uncle, all within a 3-month time period. Plus you add to the fact that she's LGBTQ plus and has to deal with that in a small rural county. She's had some significant challenges with that. And trying to help her through this has been challenging. Fortunately, she's doing much better. But she went through it, and I did not know about these programs at this time. So this is why, again, I'm going to tell you, I'm very passionate about it. Here's just some data from the Kaiser Family Foundation that shows Kentucky is exceeding the national average on individuals that reported anxiety or depressive disorder in February of last year. In a 2-week window in 2023, there was a higher percentage. This is not what we want to be excelling at. Another study they did found that, again, a higher percentage of individuals in Kentucky who had that were unable to access the services that they need to address that. Again, this is a huge concern. We have people who are unable to get the services that they need. So we want to correct that. And that's why this is, talking about the crisis continuum. The Kiprick Foundation has done some studies, and I love the data that we're able to find. If you look at the intentional self-harm data from 2022, the 13 to 17-year-olds had the highest percentage of emergency department visits. 13 to 17-year-olds, which is kind of scary to think about because they have so much going on. The Kiprick data that they did between 2011 and 2021, in that decade, you can see the increase in drug overdose deaths that have occurred. And again, we're above the national average. Other data that we got from Kiprick was the drug overdose death, unintentional. You can see in 2020 spiked. What happened in 2020? We had the pandemic that shut everything down, that cut off access to our resources and our services. It increased again in 2021. So we continue to see the impact of what happened during the pandemic and the mental health concerns that it brings. What's of particular concern is the suicide drug overdose deaths has continued to increase. So we're dealing with not only suicide, substance use disorders and suicide, but we're dealing with comorbidity with individuals dealing with both. Again, another thing from the Kaiser Family Foundation, Kentucky is above the national average on the suicide rate. More Kiprick data shows that the age group that committed suicide at the highest rate were those 65 years and older. Is that surprising to anyone that 65 and older would be the ones to commit suicide at a higher rate? In some instances, yes, and others, no. When they further broke it down, they also found that white males are more likely to commit suicide than any other demographic. So we're looking at white males, 65 and older, that are the highest percentage of suicide. And I don't know about you, but I know a couple of white males, older, especially my dad, who's like 80. He's not going to go get help for anything. And he's been a first responder. He's been in the military. He's done it all. He's not going to go get help. So how do we stop this trend? How many of you have heard of the National Suicide Prevention Lifeline? Good. Everybody's heard of that. What's that phone number? It is now. That's the great thing about it. So just some background on it. The National Suicide Prevention Lifeline was founded by SAMHSA, or the Substance Abuse Mental Health Services Administration. It was started in 2004, but it actually launched in 2005. And it was a suicide prevention lifeline with the number 1-800-273-TALK. You may have seen these posters all around. You may have seen magnets. Some of you may still have those magnets on your refrigerator. But it was that number to access for someone in a suicidal crisis. It has since expanded In 2006, they added a Spanish language network so that those who prefer to speak in Spanish to someone with that lived experience has that access. In 2007, they added the partnership with the Veterans Crisis Line so that anyone in a military-connected family could have access to someone with that lived experience. It has now since grown to about 215 centers across Kentucky, across the country, and Kentucky is one of that network. That number is still active, it is still accessible, but how easy is that to remember compared to 988? Now, I'm gonna date myself, but I can remember growing up when we had to dial 7 digits to get to what's now 911. And it depended on if you needed fire, EMS, or police. And I grew up in a small rural county here in Kentucky. Now we have 911. And who do people call for whatever the emergency or the crisis? They call 911. So we want to change that. We want to help everyone in Kentucky recognize that 988 is now the number to call, but it is not just for suicide. 988 it was launched on July 16th, 2022, and it expanded the services and became the launching pad for the Crisis Continuum for behavioral health. So what it does is it now says the Suicide and Crisis Lifeline. And what is a crisis? A crisis is whatever the individual experiencing that says it is. What's a crisis to me may not be a crisis to you. So that's why it is so important to recognize that this is accessible for everyone. In 2023, just last year, recognizing the need, they expanded and they added an LGBTQ plus subnetwork for those that are 13 to 24. So our youth and young adult who are questioning, who are experiencing mental health crises, or feeling that they are being bullied or targeted because of how they identify, now have access to people with lived experience with that. Just last year, they also added the Spanish and chat and text access for individuals who prefer to speak to someone in Spanish. So we continue to expand the nationwide network on that. And that's the thing about it, it is a nationwide network. But it's not just the phone number that's important with that. When SAMHSA rolled this out, they created a vision for the crisis services. And the first one, they're called pillars, they're called the horizons, but the first one is someone to call and someone to talk to, and that's what 988 did. It provided that access, whether you're calling from a landline or a cell phone, that you can talk to someone, whether you prefer to chat, text, or call. The goal was that by 2023, 90% of all contacts would be answered in state. And fortunately, every state is set up different, and I'll tell you how Kentucky's structured in a minute so you understand that. But we're still working to achieve that goal in Kentucky. We're still working to achieve that nationwide because the call volume increased so much. It was just astounding, and we'll talk a little bit about that. The second phase of that we're working on now, in addition to the someone to talk to, is the someone to respond. And that is very critical because we want to provide the least restrictive, most accessible services to an individual in crisis. Right now, what happens if you see somebody experiencing any type of crisis? We already said they call 911. Who responds when 911 is called? Police, EMS, and that's not always the best option for the situation. Sometimes that can exacerbate the situation. So we want to make sure we have someone to respond. And then the third phase of it is having somewhere to go for help. I mean, having that access, and we'll talk about all these in a little bit. So we've done this for almost 2 years now with 988. And we want to make sure that we are continuing to make it accessible and equitable and available to everyone, so it continues to evolve. But we're constantly looking at it in Kentucky to make sure that we are creating an effective system for all Kentuckians in crisis. And we'll know that we do that when we know we can connect someone experiencing a mental health or suicidal crisis to someone that is trained to de-escalate that, who can provide them resources and referrals to meet that crisis. We want to reduce the healthcare spending because all too often, someone experiencing a substance use disorder either ends up in jail or in the emergency department. And that's not always the best option for that. So we want to reduce that by providing cost-effective services and early intervention for those experiencing those crises. We really want to reduce the use of law enforcement and EMS because think about it, it is a revolving door in a lot of cases. There's not that continual support, that community support to help that individual in crisis. So we want to make sure that we're helping our first responders be able to do what they're trained to do. The one thing I hear from first responders when I go out and talk to them is, I don't do mental health. But the reality is they're doing it, but they're not doing it with the training that they need. So that's why we want to make sure we're having an effective system. We also want to continue to meet the growing need as it continues to grow. We want to deliver it equitably, but we also want to serve the most high-risk populations that are least likely to contact or have the most culturally diverse backgrounds to reach 988. We did an awareness survey, and it's similar to the QR code that I put up there. We did it for the state fair, just to get a baseline of how many Kentuckians had heard about 988, knew what it was. What we found were high percentages of African Americans and LGBTQ populations in Kentucky knew about 988, but they were also the least likely to use the service. So we've got work to do, and that's why I appreciate the opportunity to share this message. So let's talk about the someone to talk to, the first pillar of it. Anyone can call 988. Right now, if you were to pick up your phone and dial 988, it is going to be routed based on your area code and your exchange. So I have two phones, one's for work, one's personal. If I called 988 from my personal phone, it's a Louisville-based number, I'm going to be routed to the Louisville Center. If I call from my work-based phone, which is a Frankfurt number, I'm going to be routed to the Lexington Center because that is how they're routed right now. And that's important to know because does anybody in here have a non-Kentucky cell phone number? Because if you do, you're going to be routed back to the center within the state for which that number is affiliated. Now, again, this is a network, so you're always going to be connected with someone. But if you live in Kentucky with an out-of-state number, or you're a Kentuckian with a phone number that lives out of state, you want to be connected to the most local resources. And that right now, that's not always how it operates. When you call 988, everyone's going to hear a greeting giving the options. And I kind of mentioned it before. There are 3 sub-networks that you can get connected to. Sorry, hazard of being a first responder. Okay, and I quieted my phone. My apologies. But you will get the option. If you are a military family or connected to the military, veteran or active duty, you can select option 1 and be connected. Spanish subnetwork is option 2, LGBTQ plus is option 3, or you can stay on the line and be connected with that local center. In Kentucky, it's going to go to the most local center affiliated with that phone number. But if that center is not available, it's going to go to the state backup center. And it's going to be answered by someone within Kentucky. Now, if there is a situation where that center is not available, maybe they're getting a lot of calls, it can roll to a national backup center. So there's always going to be someone to take that call. And that's the key thing with this. This is a network of more than 215 centers across the country, where they're all trained to de-escalate the crisis, to evaluate, to assess, to triage. Every call that comes in gets screened for suicidal ideation. Every caller that calls in gets triaged to determine, are they having homicidal ideation? Are they in a mental health crisis? Are they at imminent risk of harming themselves? So these screenings occur in January, and we get data every month. Our centers, and we have 13 currently, answered calls within 24 seconds of being routed to their center, which is better. Finally, we're better than the national average. The national average runs about 30, 32 seconds. So our centers in Kentucky are answering at a much faster rate, meaning that they are also able to talk to the individual faster before they get a chance to change their mind or decide to hang up before connecting. Now, another important thing with that, sorry, apparently things are going crazy. Another important thing with that is our call averages. A call can vary. Some call centers average about 9 minutes per caller. Some of them can go up to 15 or 20 minutes per caller because they're going to go through the screenings, they're going to do the triage, and they're going to talk to that person. And they're going to find out what the situation is. So even though we have our centers in Kentucky, it's important to recognize it doesn't matter where you are, you can get access to trained crisis counselors anywhere in the country. So even if it's not a Kentucky-based center, you're going to get the same trained crisis intervention specialists, is what we call them in Kentucky. But they're going to be able to identify and provide resources. How can an out-of-state center provide resources? They're part of a network that they can pull up, and they can either transfer to the local center if that person identifies where they're from. And that's one of the key things about it. You never have to disclose, nobody ever has to disclose any more information than they choose to. Our crisis intervention specialists do not ask for names, locations, any identifiers. It is completely confidential. Only the information that the caller chooses to share is what is communicated. Now, if someone is at imminent risk, yes, our crisis counselors are going to work to identify them. But on average in Kentucky, we are able to de-escalate 98% of the calls. On average, from what we have found so far, about 1.5% of all of our calls, chat and text that come in every year, 1% gets transferred using emergency services or a mobile crisis team. The majority of our calls are de-escalated and provided resources. But it doesn't just end with that phone call. Our trained crisis counselors will ask, can we follow up with you? Can we call you back and make sure you're okay? Can we call you back and make sure you were connected to this appointment, to this resource, to help make sure that you are continuing that path of stability? And again, it's by consent. Now, there are some instances where if someone does end up being at imminent risk, they will attempt contact just to make sure that they were okay after dispatching emergency services or mobile crisis teams. But for the most part, it is all based on caller consent. So I talked about the sub-networks, and this is just kind of an overview. The Veterans Crisis Line, again, is available. And if a veteran or if a military connected family happens to reach a local center and they mention that they're military connected, the crisis intervention specialists will connect them to the Veterans Crisis Line if they so choose. Because again, it is about voice and choice of the caller. Another great thing about 988 that's different from what was the NSPL is it can be a third-party call. So if I start acting withdrawn, depressed, and normally I'm a very talkative person, which is probably why I can't talk today, but if I suddenly start withdrawing and not doing that, my family, my friends, they can call 988 and ask what to do for me. They can get those resources. They can get that information. So it can be a first-party call. You can call about yourself. You can call about someone that you're concerned about, and they will get you the resources that you need. Same thing with any of the sub-networks that we have. So I told you that Kentucky is part of the network. Right now we have 13 centers. We got 14 community mental health centers across Kentucky. And the decision was made in the planning phase of 988 to keep it as local as possible. Every one of our community mental health centers operate a crisis line. So it made sense to put the 988 crisis call centers within this community mental health centers. We are thrilled to announce that by the end of the year, all 14 will be 988 accredited centers, because Comprehend, that's in the upper right, is actually going through the process right now. So every Kentucky county is currently covered primarily by 988. With Pennyroyal is covering for Comprehend at the moment primarily. So we're about 86% on our counties for backup, but that's going to change when we get Comprehend on board, so we'll be able to shuffle some things around. The call volumes, as you can imagine, Jefferson County has the highest call volumes in Kentucky. So a lot of our centers, some of them get 32 calls a month, Some of them get 700 to 1,000. So finding the right fit to make sure we can continue to answer those calls are very important. But that's what we continue to work on with that. These are just some slides to show you how we've progressed over time. So you can see in 2021, we pretty much went from 22,000 calls to last year we had over 30,000. So since the launch of 988, we had a significant increase in that. The first weekend of launching 988 after the governor's announcement and the launching of our website and things, we had, I believe it was 117% increase in phone calls in the first weekend. So we knew that the message was out. And you may not have seen a lot of 988 marketing because we have intentionally not marketed it very heavily. We've done a very soft marketing because we wanted to make sure we could build capacity. Between 2021 and 2022, we had a 16% increase in calls because of the launch in July. We had a 17% increase in 2023 over 2022, and we anticipate that again as we move into 2024. And so these are just kind of an outline of, we track calls that come into the centers. We track the calls that are answered in state that go to the national backup centers, and then we also track calls that are abandoned. We do not want calls to abandon, but again, it's by caller choice. So some people call, they'll dial 988 just to hear what it says. And then that shows up as an abandoned call. So we recognize that those things happen. We recognize cell service is spotty in some parts of the state, and the calls could drop after connection. So we continue to evaluate that and see what we can do on our end to make sure that we do not have callers abandoned in the process. Now, back in the fall, we started getting kind of curious because it is the Suicide and Crisis Lifeline. And we wanted to know why people are contacting 988 in Kentucky. Because we have had kids as young as 8 contact our centers. 8. So it is heartening to know that we have that resource available for our kids. But you can see in December of 2023, the highest ranked reason for calling was suicidality, followed by family or friends issues, and then mood issues, which could be anxiety or stress. It could be anything. So we know that putting it out there, the number is working. We also now have the chat option. And by clicking the link or going to the 988lifeline.org/chat, you complete a brief survey, which basically gets into zip code and name or alias and the reason for the contact. And you're connected to trained chat counselors. There's a different set of training to go through for chat and text than there is for calls as far as how to communicate, because it's a lot slower process with that. We have one center in Kentucky that does it right now on a limited basis, and we're adding more. We know one will be on board by the fall, and then we're going to look at adding more to it to make sure we answer more chats in Kentucky than them going to the National Backup Center. But again, it is by the individual's choice. So we recognize that they may not give their name, and that's okay. They can give an alias. It is all about the contact choice. This slide just kind of shows you the volume from 2021 to 2023. We continue to see that significant increase in the chat option. It's just kind of a quarterly comparison where you saw last year between April and June, we had a pretty significant spike in our chat messages. Then there's the text option. Now, I don't know about you all, but I would much rather text than talk. And I hear all the time, what demographic tends to be texters? Are younger people. And so we have this option available. And if you remember when we talked about older white males that tend to have higher rates of suicide, how much better is it to be able to be in a meeting? You could be sitting here now and being stressed out. You could text 988 and talk confidentially, and nobody's going to know. We have that option now with the chat and text capability. And again, it's going to go to the local center, and then it'll go to the national. So there are lots of options to make it accessible to individuals experiencing a crisis. This is kind of the illustration of how our texts have increased. So we had quite a spike in 2023, huge spike in the text volume, and we anticipate that to continue going up as more and more information is put out. This slide just kind of gives you a comparison of the referrals in the emergency services, because as I said before, 1.5% or less of all of our calls get transferred to emergency services or a mobile crisis team. So you can see the blue is the actual calls that were received. The orange is the mobile crisis team. The gray is actually, I think, the dispatch, and then EMS, law enforcement. So our crisis counselors, our intervention specialists, they do an amazing job at de-escalating. Yes?
I'm just kind of curious. So in terms of mobile crisis, whatever, you know what I'm saying? It's late. Is that available in every county? Is it available just some regions?
Well, it is.
I'm assuming that someone will come to the house and say, what does that mean?
That is actually a very good question, and that is one of the things in the next phase we're going to talk about. But I will tell you right now, every community mental health center has a form of mobile crisis. Now, I say a form in that some centers will only do telehealth, and they consider that mobile crisis because COVID changed. When people couldn't go out, they set up telehealth. They made it that much more accessible. Some of our community mental health centers will put tablets in the hand of law enforcement. If they encounter someone having a behavioral health crisis, they connect directly to that center for a trained clinician. Others will physically go to a location, but it might just be a school or emergency department. But the world of mobile crisis is changing, and that's what we're working on now. So that's a very good question. Thank you. Okay, so like I said, you can see we do a lot of referrals for mental health and getting people connected to resources with that. But they also do referrals for food banks, for electricity, for rental assistance. It's whatever the crisis is determined to be by the individual reaching out to 988. So they maintain these resource directories to provide those services. Let me see what I'm doing here. Okay, so someone to respond, very perfect. So right now, this is what the behavioral health responses typically look like. Too many times in the past when I would hear listen to the radio at home, I would hear law enforcement sent out to little Johnny, who's acting up and doesn't want to go to school, and mom and dad call 911. Is that a law enforcement matter? No. All that does is create some trauma for the child that, if they're bad, law enforcement is going to show up. But it takes a law enforcement officer off the streets from doing what they're supposed to do. So instances like this, where someone with a developmental or intellectual disability and families don't know where to turn, they call 911. Someone who has, an older person who may be dealing with dementia or some sort of cognitive change. I hear all the time on the scanner and on my radio, mental status change. What does that mean? So we're working with our first responders. We're working with our dispatch centers to say, let's take these calls off EMS and fire. Let's take these calls and divert them to a 988 center so that they can talk to someone trained in these situations and reduce the use of law enforcement and EMS for non-emergency or non-criminal situations. But it's been a revolving door in a lot of cases because there hasn't been a system in place. So people call 911 on something, and the individual likely either goes to jail or to the emergency department. And I had a friend I tried to help one time before I even knew about 988. And we went to high school together. And I didn't realize until we had talked for a while, he was an alcoholic. And I started seeing the pattern. But he would go out, binge drink, pass out, go to the ED, be discharged with no resources once he was medically stable. 2-3 days later, guess what? He would do the same thing. EMS would pick him up. He'd go back to the hospital. He'd be discharged with no resources until he had I think 2 DUIs in a month. So then he went to jail. So He texted me the other day, said he's sober and doing well, so I'm tickled to death. But we're trying to break this cycle. We want to get people to where they have access to behavioral health. And the American Psychological Association estimates that 20% of all calls involve law enforcement that have mental health or substance use crises. That doesn't mean they're committing crimes. It means that people don't know who to call. And emergency departments, according to the Kentucky Hospital Association, in 50% of the 2.4 million visits were for mental health or substance use disorder. And in 2020, 53% of all emergency department visits. Pretty staggering. So that goes back to how we recognize that we're reducing the healthcare costs and we're connecting people to resources that they need. Just a slide from Kentucky Hospital Association showing the increase from 2016 to 20. And then on the age brackets. So in 2016, the 25 to 34-year-olds were the ones that reported most often for substance use or mental health diagnosis. So there is a trend in that, and this is what we're trying to reduce. So what we want to get to is something like this, the someone to respond. We want to work with our PSAPs and our emergency services to say, if you get a phone call and it's a behavioral health crisis, transfer that to 988. Let us take that and provide the resources, because ideally, we're going to have the mobile crisis teams. That doesn't mean we're cutting law enforcement and EMS out, because things change. And if you've ever been around a 911 center, I know this is shocking, but not every caller provides the whole story or tells the truth. It is very shocking sometimes what comes in and what you actually find. So we want to change that. We want to take that off our 911 centers and say, send that to 988. Let us do that and de-escalate the crisis and provide the services. Because it's not just, like I said, it's not just talking to them one time. It's providing that referral. It's providing that follow-up with their consent. It's getting to this whole wraparound system of connection to the resources that they need. This is what we're moving to in Kentucky, working with the Department of Medicaid Services. They're implementing a mobile crisis team, and it is going to be across the state. They're going to utilize the various contracted agencies, whether it's a community mental health center or a private entity, but they're going to have trained behavioral health clinicians, peer support specialists, those with lived experience, to go out to the individual where they are, whether that's in the parking lot of Kroger or if that's at a school, if it's at their home. So they want to make sure that they're providing the least restrictive access to the services that they need. But it's not just there. They want to make sure that they get them where they need to be. And ideally, if it's a situation and it's deemed to be important enough, they're going to work on voluntarily getting them to go to a center for crisis stabilization, to go inpatient, to go into rehab, whatever the situation may be. But then they're going to continue to have that wraparound services to make sure that they're getting the access that they need. This is continuing to be developed, and we're at the table with that. And I think it's going to be something really amazing, because we already know in a lot of places, access through transportation is a challenge. Underinsured and underinsured individuals experience those barriers to getting the services. So we're continuing by starting 988 is that entryway into getting those services to them, because they may not know where to go. So we talk about a safe place to go. That's the third pillar of that. Right now in Kentucky, like I said, every community mental health center has walk-in crisis stabilization units. If someone's experiencing a crisis, they can go into these crisis stabilization units. They're typically like about 23 hours. They're monitored, they're given a snack and just kind of watched and talked to make sure that there's nothing significant going on. And then there's also residential crisis stabilization. So these services are available, and the link at the bottom, you can go and access what services are available for what county through what center. And so we do have a lot of services available in the state. But the thing with 988, like I said, it is not a new program. It is a new system built on an old one, and that is expanded access. It is providing those resources to individuals who may have nowhere else to go. And we're working very hard to get people to understand 988 is to behavioral health and mental health what 911 is to medical and other emergencies. But it's getting that information out because we are transforming the crisis care continuum. And it is considered to be one of the most significant behavioral health policy efforts since the Medicaid expansion, because we are providing that entryway and that access to it. So again, we want to spread the word. We want to share the information that whether you or someone you encounter, someone you work with, someone in your church, your network, if anybody has a behavioral health crisis, even if they're just particularly stressed. And I often joke about it the last 2 weeks, if you've ever written SAMHSA grants, I had 2 of them due at the same time, plus a report. And I was like, I wish I could talk to someone. Oh, wait. I didn't know, fortunately. The family was like, okay, calm down. But if I had gotten that stressed out over it, I could have called 988 and not batted an eye and been able to talk to someone to help me in that crisis. This just kind of gives you an idea of the direction we're going when we're transforming. As I mentioned before, every one of our centers have their own local crisis line. We have some who have 3 or more in addition to 988, so they operate different crisis lines. We are seeing a shift in the calls because the crisis lines are either a 1-800 number or they're a 10-digit number locally. So again, which is easier to remember, a 10-digit number or 988? So we're seeing the shift in the increase in 988 calls, but the decrease in the community mental health center crisis lines. And the important thing about that is 988 is a network nationwide. The crisis centers are their local centers, so there's not a backup to that. We're not stopping there though, because the response does not stop with that initial 988 contact. We are working to develop the mobile crisis teams. And again, we're working with the Department of Medicaid Services on that, to have the trained professionals, to have the peer supports go out who can relate to that individual. We're looking at co-responder models. We're working in Perry County right now on a grant that they are using EMS to start to build a behavioral health response because of the rural nature of it. They're training their paramedics and EMTs to be able to respond to that without lights, without sirens, to have the tools to address that, and then make sure that they're connected back to local resources. In Jefferson County, some of you may have heard of the deflection program. It's not directly tied to 988, but they do have trained behavioral health specialists embedded in the 911 center in Louisville. And if the call takers in the PSAP or the 911 center recognize that it's a behavioral health situation, they transfer it to the next queue over. And the behavioral health specialist then will talk to the individual and either de-escalate it or send out mobile crisis. So there are a lot of models that are working all across the country. And we're looking at a lot of different things in Kentucky, knowing that we need to address the mental health crisis, the substance use crisis, and in particular, our children, because there is a significant need for resources for children. And so we're looking at various ways to address that as well. And then there's things that are co-response models, partnerships with law enforcement and behavioral health, where they go out together and they address that need. Part of that's for safety, because if you're a clinician or a peer support, you don't necessarily know what you're getting into when you walk into someone's home, especially if they're having a suicidal crisis. And we recognize that, again, the white males and those in the military have access to weapons. I have access to weapons. I have them in my house. And if I were suicidal, they're going to ask me, do I have access to those? I'm going to say, no, they're locked in my safe. And they're going to tell me, okay, good, keep them there. But they're also going to tell the law enforcement that, so that everybody is on the same page. So it is a continual work in progress and a continual development of that. So the link I put up before is one of the surveys that we're doing. We want to gauge awareness. We know a lot of people have heard about 988. We don't always know that everybody knows what 988 is. So we're trying to gauge that so we can make sure we're addressing the information and sharing it as we need to across the state. We're also working to build a dedicated 988 workforce, building a network among our 14 centers that work together to address the calls and make sure everyone is getting the same training, everyone is getting the same access and the support. They do now, but they all operate as 14 centers. And that's great, but we're slowly building it to where it's one network. We're doing marketing efforts for our high-risk populations. We've partnered with the University of Louisville to do what's called a boot camp translation. And that was focused on our 2 highest risk populations for suicidal ideation of African Americans and LGBTQ, which, if you remember, I said they are the most aware of 988 and the least likely to use it. So we're doing an awareness campaign with that. We provide cultural awareness trainings for our centers so that they are skilled and comfortable addressing farm issues or talking to someone from the military and have those resources. We're working with emergency services so that we can build these relationships to help them understand we're trying to take this workload off of you. I'm dating a gentleman that we've been dating for a while. He's an EMT in a rural county. He has heard more about 988 than I think he ever cared to, because we will be sitting somewhere and I'll be like, wait a minute, how about this? And he'll tell me about some of the calls that they do. Call them frequent flyers, if you will, but individuals with mental health crisis who have nobody else to talk to. So they call 911, sometimes 3, 4, 5, 10 times a day. And EMS has to go for that. So I'll pitch ideas off of him. I'll talk to my first responder friends where I'm on the fire department. We're trying to build that and educate so that people are aware of the resources available. We've got a feedback survey where we're trying to make sure we have quality improvement for those that have used the service. So far, we've had the survey open. I can very proudly tell you we have had 100% satisfaction. Everything was ranked amazing. But I also let you know that we only had 1 response. So we'll take it. It's 1 response of 100%. But we do take those seriously. So we're trying to share that information to get the feedback, to make sure we're providing the best possible service. And then we're continuing to add chat and text capacity. So all of this, like I said, not only transforming the crisis continuum, but building a safer Kentucky. And that takes every one of us. So I have some opportunities for you. We have a coalition that oversees the work that we're doing on that. When it started, it was about 75, 80 people, and that was for the planning phase. So we've pared down. We've got an emergency services work group where we need not only first responders, but hospital representation. We need individuals that are familiar with this to come and help us build out that piece of it. If you're good at marketing, hey, come join our marketing group. We've got a lot going on with there. But there's also regional coalitions that you can join to help on the regional level at our community mental health centers. You're also welcome to invite me to come do presentations, because I guarantee most of the time I have a voice and I'm not squeaky. But we can definitely coordinate that to educate and then be an advocate. Share the information around, share information about 988. You can find all kinds of things available on the SAMHSA Partner Toolkit. And you can order the materials for free. There's wallet cards, there's posters, there's all kinds of things that you can get. They have social media downloads, share on your socials, share on your organization. But let's help get the word out and educate people about the importance of it. I'm trying to keep within time, and there is so much. I could talk for another hour on the mental health resource website that we're building, that we're going to launch. So pay attention, come in a couple of weeks. How we're changing things, what we're doing with that, how we're working with our partners. But I will pause because I know I've been talking for a while. Does anybody have any questions about 988 or what we're doing in Kentucky? Yes, ma'am.
So for mental health professionals, they're mandated to report 202As, 202Bs, and things like that. What is the vision for 988, in that realm?
To prevent them. We want to have early intervention. We want to get people before they get to that point and connect them to the community resources so that they have access to it to reduce those. That's what we're working towards. So very good question. Thank you.
How often does the regional coalitions meet?
Some of them are meeting monthly, some of them meet quarterly. It depends on how big their coalitions are. Most of our state level meetings meet monthly for an hour. We try to keep it at that, but
Is all that information on the website?
it is not. But I will tell you, if you have any additional questions or need information, please feel free to contact me and I will definitely connect you with the appropriate center. These are amazing questions. Any others? Yes.
Talking about determine where you direct those calls.
Mhm.
Is that something that they're looking to change so that it's based on your location?
Mhm.
Or, yeah.
It is, and that's why I said for now that they are based on area code and exchange. There is talk with the three major carriers of cell phone coverage that they will do a rolling implementation of what's called geo-routing. And geo-routing is not what 911 uses in the geolocation where they can pinpoint where you are. Geo-routing will connect to the closest cell tower and connect you to the center that's in close proximity. So the 988 call to, crisis intervention specialist taking those calls will not know your exact location, but you will be routed to the most local center. And that's why we're trying to build the capacity, because we know between the universities and the military bases that we have in the state and people relocating here, we want them connected to the local resources that they can have access to. So very good question. Thank you. Any others? All right. Well, thank you all very much. Feel free to reach out anytime if you need materials. I brought a few magnets and posters and wristbands. If anyone wants a wristband, I'm happy to share. But we definitely appreciate your time, and feel free to reach out if you have any questions.
Thank you, Angela.